All right. Good morning and thank you for keeping it Citizen Television. Of course, it is the pink month, October. That's why I'm in pink. Pink is the color that is used to elevate awareness around breast cancer. I say elevate because raising we have done. We've done a lot in terms of just passing that information about breast cancer out there and making sure that each and every person, regardless of where you are in this country, you know something about breast cancer, be it a woman or a man. But we may never assume that each and every person is on board when it comes to awareness. So that's why we keep doing this every time we get an opportunity. And today on Health and Lifestyle, we dedicate it to talk about breast cancer. And it is actually a leading they say it's the leading among women in Kenya and even globally. It causes cancer deaths that are caused by breast cancer actually highest when it comes to categorization. I was looking at the numbers in Kenya, and of course we are reporting about 7,000 cases annually and a mortality rate of about 3,000 deaths per year are reported as a result of cancer. It depends on how you interpret these numbers, but what we want to do is to reduce these numbers as much as we can. And if you're watching us this morning, you're not part of the statistics yet, we celebrate you, and this is why we're having this conversation to help you prevent. But if in case you're part of these numbers, we also celebrate and salute you as a warrior, as somebody who has even survived cancer. And this theme, the theme for this year is centering around those stories that you have as people who have worn those that particular shoe. So allow me now bring on board my guest for this particular conversation this morning. And we are going to be breaking down this conversation bit by bit together with Dr. Gladwell Kiarie. She's a consultant medical oncologist. Asante sana for creating time for us.
Thank you for having me on the show to have this important discussion.
All right.
Yes.
Dr. As we sit down today, and just before we even began the show, I was telling you, we may assume that we've had this conversation over and over again, but there could just be somebody who's watching this for the very first time, or they're watching and they'll find out something new for the very first time. What will be your opening remarks, as we mark this pink month, the month of awareness around breast cancer?
Thank you very much. And I think the most important thing is probably what the WHO theme is for breast cancer awareness this year, is that every story is unique, every story matters. So we'll have different people, as you've said, with different unique stories, different challenges, different hopes, and also different outcomes. So we are putting a face to every story. And I think I'd like to open this discussion with saying that awareness is very important, so that every person listening on this show can know I'm at risk of breast cancer. And sometimes, you may say that I eat well, I exercise, I drink water, and therefore I can't get breast cancer, and that is not correct. Everybody is at risk. As you've correctly said, breast cancer is around 23% of the malignancies in Kenya. That statistics ranges up to around 15% when you look at all malignancies across the board, and that's still a very high number. It's our commonest cancer in women, and 2% of those cases are actually men. So I'd like also that we increase the awareness among men for them to pick up breast cancer in themselves if they have it, and also in their spouses, in their girlfriends, in their mothers, in their sisters, to be able to offer the support so that an early diagnosis can be made. So this awareness is a call to action, create the awareness, increase knowledge, and call to action at whatever level we are.
All right.
Yes.
All right. So before we even get deeper into this conversation, Dr. I was looking at the variance in terms of the numbers of incidences and the numbers of those who die because of this type of cancer. And it's almost half of the population.
Yes, it's almost 50% mortality.
I'm wondering what this means for you, as an oncologist. How do you interpret these numbers?
When you look at Western countries where the survival of breast cancer is actually increasing, and you look at our own setup where 50% of the patients who are diagnosed will die within the year, it's a very concerning statistic. And you look at that and see that 3/4 or up to 68% of cases in Kenya are diagnosed as stage 3 and 4. Now, that does not equal death or mortality in the same year, but it means that the cost of care is much higher and the requirement of support is much higher, and what the individual person will go through is probably more trying than when an early diagnosis is made.
All right.
So probably the theme about, every story is unique, every case matters, and putting a face to breast cancer is to push out the message there that at every level we are, whether, it's self-breast examination, it's making sure that I go for that annual mammogram, it's making sure that my sister has a lump and let's support her to go and get an early diagnosis. We must push early diagnosis so that survival is higher, the issue of morbidity is lower, and therefore the suffering and so on is much lower, and the sort of required community support is also much lower, so that we get as good figures as we get in Western countries, because good outcomes in breast cancer are very possible.
Yeah, and it's good that I think you have really insisted since we started this conversation on early diagnosis.
That is very important.
Because late diagnosis remains one of the biggest obstacles when it comes to survival rates.
Yes.
And we'll talk about now how do we change the narrative, because the burden seems heavier this side of the world, because many people go to the hospital when the cancer is already advanced and managing it becomes more complex and survival rates are shrinked. So we want to talk about how do we change this particular narrative so that we save more people. But before we get into that part of the conversation, Daktari, let's start from the basics. We're talking about breast cancer. Just run us through the anatomy of a woman and how then does the cancer affect this very special part of the woman's body.
And remember, as you mentioned, the woman, the man too has a breast.
2%. That's
of men will
get
get breast cancer. Yeah. And therefore, the breast is a mammary gland. It's the breastfeeding organ in the body that breastfeeds the baby. And as much as men too have a breast, it's much smaller with no ducts, for breastfeeding. But the gland is actually made up of what we call lobules. Lobules are just little sacs where milk is stored, and then there'll be the single layer cell duct that is a little pipe that carries milk to the nipple. So lobules store the milk and ducts carry the milk to the nipple. They all lead to the nipple. The size of the breast is determined by the amount of fat tissue that women have. So women can have a small breast, but it produces enough milk to breastfeed the baby. Then there is fat in the breast, and that determines who has bigger breast and smaller breast than the next person. Then below that, we have what we call the pectoralis muscle, where the fat tissue and the lobules and ducts lie on. And then, of course, we have the overlying skin, and we have the hyperpigmented nipple with the areola around it. So basically, that's the markup of the breast. Now, majority of the cancers occur on that single layer duct that is a pipe that carries milk. It's a little pipe with a single layer, and that's where most cancers, up to 80%, will occur. Remember that the cancer can also occur in the lobule. We call it invasive lobular carcinoma. When we have it in the duct, which is the most common, it's invasive ductal carcinoma. Cancer can occur on the skin of the breast. Cancer can occur on the muscle of the breast. Cancer can occur in different parts of the breast as well. But when we talk about breast cancer, we are talking about invasive ductal carcinoma and invasive lobular carcinoma. Now, as I talk about the presentation and the different symptoms, our emphasis should be on picking this cancer before it is symptomatic, before you feel a lump, before you have any pain, before you have any breast discharge, before there is any change in the skin, is when we should diagnose breast cancer. And how can we do that? Through screening. And this is where we tell women to go for their annual mammogram and to go for their annual ultrasound. And it's very important to have a doctor do a breast examination, and also to teach women to do self-breast examination in premenopausal women before their period, in postmenopausal women at any time. Just do the 5 steps of self-breast examination, like standing in front of the mirror, putting your arms akimbo, lifting your arms to be able to see whether there is any tethering in the breast, any color change.
Let me just cut you short.
Yes.
You've said so much, very important information. In fact, even taking us through the types of cancers and how they affect the breast. But I also want you to now slowly take us through the different types of, examination to detect these cancers.
Yes.
The key types. There's the one that I can do myself in the comfort of my home.
Breast examination.
And there's the one that you really also advocate of going to a medical facility to get that done. So talk to us about these different types of doing it, and why we should either use both, or why you should insist on one as compared to the other.
Thank you very much. So self-breast examination is what I'll speak to first.
All right.
And we'd encourage even young women to do this after their period, when the breast has less tension. And then, of course, the other modalities of examination is going to a doctor to examine you, because our doctor may pick skin changes, may pick skin tethering, and may pick lymph node or swelling under the armpit. And then the other one, of course, is to go for the screening modalities like a mammogram or ultrasound, which we call imaging. And therefore, if a lump is found, to go for a biopsy. So the importance of the self-breast examination is for a woman to know her breasts, to be able to feel that the right one looks bigger or feels bigger this time, compared to the last time that I did the examination. And it's for them to identify any reddening or color change on the skin as they stand in front of the mirror, to be able to see any enlargement, to be able to lift their arms up and see if where the breast cancer tail goes to the armpit, there is any change or there is any swelling of lymph nodes under the arm, which is the first place that breast cancer spreads to. Sometimes when you lift your arm, you can see the nipples on the right and left breast should be at the same level. But when you lift your arms, sometimes you see one nipple is lower than the other, meaning that it has been tethered or pulled to the chest wall. And that actually is a warning sign. So then the woman should lie down and, using the palm of her hand, be able to use the right arm to the right palm to examine the left breast and vice versa. And also, standing up, be able to palpate her breast, and also sort of put pressure on the nipple to see if there is any discharge from the breast.
How regular should this be done?
Every month. It is very important for women to know their breasts and do that every month. Should your partner or, be able to feel a lump, that too is actually quite important, so that people can be able to seek the proper professional advice they need when they find a lump in their breast. Now, the creation of awareness is to destigmatize and offer hope to people who find a lump in the breast, and offer them options of seeking, the proper diagnostic procedures. Some people panic and they say, oh, let me wait for it to disappear. And sometimes they come too late. Others never find the lump, because a majority of those lumps are painless when they are most dangerous. And therefore, we advise women not to wait for the pain to come, not to wait for the discharge to come, but actually to seek a diagnostic procedure very early.
Do you think a concern also should be that many women do the self-examination, but they don't know what to look out for? They end up missing the obvious signs. And then there's one who also could be asking, Daktari, I do this regularly, so why should I go to the hospital?
Very important. So in just general health measures, we all need a medical exam probably once a year. I usually tell women that on your birthday, gift yourself with going to a doctor to examine you and then do all your medical checks, especially after the age of 35, 40. Make sure that that is done. Sometimes a doctor can pick what you did not pick. Sometimes a doctor can direct you what to look out for the next time that you do a self-breast examination. And the doctor will send you for the correct screening test. A screening test means that you don't have any symptoms and you're going to find for the smallest thing that cannot be felt. So when a woman does a mammogram or an ultrasound, they can be able to pick a lump, they can be able to pick a swelling under the armpit. The examination can be able to pick what we call microcalcifications that are not palpable by a doctor or the patient, but they are very important to make an early diagnosis of cancer. And that usually leads to a very good outcome, cure, prolonged survival, and also very little intervention in way of treatment because you've presented very early.
All right. So the self-examination is important.
Very important.
But you're advising that you should at least once a year
see a doctor. Yes, or a medical professional who examines you. Remember, in the same vein, we're encouraging women to do their pap smears, and also to remember they can also be hypertensive, diabetic, have high cholesterol. So all that should be lumped together during your medical examination.
All right. Let's talk about that medical examination and what to expect. For example, a mammogram.
Yes.
There is a very, I was looking somewhere and the numbers were like standing at 14% of women who have never gone to, reports indicate that only about 14% of women of the reproductive age in Kenya have ever had a clinical medical examination when it comes to, such issues.
Yes,
and that's a very small number.
That's a very small
number. Many don't know
number.
what to expect.
And then we may speak about the women who have no access, but let me speak to those who have access. You have an insurance cover. You have you work in an organization that offers you the support to go for a health check, and you don't. So there are those with access and don't do it. There are those without access, and that's why we talk about advocacy and policy people, so that we can be able to create access for every woman to go for a checkup.
All right. So what do I expect in case somebody has never gone for a mammogram or an ultrasound? So what does that look like, and how should they prepare?
I would advise them to, and there is no drama. There is a lot of myths surrounding going for that exam and going for the test. There is no drama, there is no harm, and actually it will not be anything life-changing. So I advise that, if you have a medical practitioner you see every year, or even if you don't identify one, go to your health center, get your breast examined, and let them feel you out asleep to get a mammogram or an ultrasound done. So all that happens is with the ultrasound, there's some gel poured around the breast, and then there's a probe that is usually pressed along the breast, and usually will demonstrate if there are any lumps or swellings or any other abnormality. And sometimes that ultrasound is the one that is used to be able to identify where the biopsy needle will be put. Now, a mammogram is a little more uncomfortable in the sense that the breast is pressed so that there can be an X-ray image made, and they are able to see calcifications. For many women, we require both to be done at once, especially if there is any suspicion of abnormality. I usually tell women that the only diagnosis of cancer is a biopsy. We have to confirm that in what we call histopathologically. So we need to take tissue, and we need to have that read by a pathologist to be able to make a diagnosis of breast cancer. And thereafter, many other tests actually follow. And we would like to debunk the myth that if I stop eating meat, if I stop eating eggs, if I stop drinking milk, the lump will disappear. It will not.
It will not. So the mammogram and the ultrasound cannot diagnose?
No. They'll create a high suspicion.
Yes.
So between the clinical exam, the imaging, which is a mammogram or ultrasound, we must get a biopsy done. So it's a triad of tests to be able to make a diagnosis of breast cancer.
So this is advanced depending on what the person coming presents.
Yes.
If you do a self-examination, then you go for a mammogram, there is nothing that is detected, you're good to go.
You're good to go. But keep it up. What is today may not be so tomorrow or next year.
Be consistent.
So you keep examining and you be consistent. Let me also raise the point about what we call targeted screening. Some people have a higher risk of breast cancer than others. If, for example, you have a strong family history of breast cancer, your first-degree relatives, you have multiple first-degree relatives who had breast cancer, your mother, your sister, your daughter, your first cousin. This is a targeted group where we'd call for higher screening than the rest of the population. So sometimes based on our family history, where we have familial clustering of cancer, it's very important to have more screening than the next person. People who have inherited genetic mutations, like, for example, Angelina Jolie, the movie star we know who had bilateral prophylactic mastectomy because she has a strong family history of breast and ovarian cancer. She lost her mother to that. So because of that high risk and testing positive for the genetic mutation, she went for just removal of her breast without even having breast cancer. Probably that's a little of an overkill. But we should actually know our family histories and our risk to some of these malignancies so that we can have what we call targeted screening. Higher suspicion, higher awareness, and awareness that our risk is actually higher to get some of these cancers. Right. So if you belong in that category, of course, the other risk we talk about using oral contraceptives and other hormonal things, you'll make sure that you don't, because that genetic mutation, and then you use that trigger of using hormonal contraception can lead to that. You know, smoking, people who've had cancer on one breast, people who had pre-malignant disease of the breast, like fibrocystic disease, have a higher risk of developing breast cancer than the next person.
You've talked about oral contraceptives as a risk factor. Is it for those who are high at risk, or is it a risk factor generally? Just shed some light on that.
Yes, those who have a genetic risk or a familial risk should not actually use oral contraception because it increases the risk.
But is it generally safe for...
Yes, generally safe.
The other population?
Generally safe, the hormonal factors. And this is what we talk about, you know, if you have a certain risk, if you have, for example, a certain disease, the awareness that there are certain things you shouldn't use because they can lead to more damage. You know, we talk about, for example, using, you know, certain painkillers. When you have a stomach ulcer, it will cause the ulcer to bleed. In the same light, if you have a familial risk of breast cancer, some of those hormonal contraceptions are contraindicated in you because they are going to increase the risk further.
Yeah, you really bring out a very important point of why people should not, you know, give themselves prescriptions.
Yes,
you need
very
to
correct.
Because you may never know all
yes,
this. You may never know all this.
You have gout and you have a little pain, but that painkiller you're taking could ruin your kidneys.
Exactly.
And cause your ulcer to bleed.
Yeah. And now that you're talking about risk factors, let's finish up with that. The age factor, also talk to us about how it relates to cancer. Yes, but
let me also debunk the myth of the age. You know, we talk about, you know, the books we read are written by Caucasians and white men.
Yeah.
And we were told that the risk grows higher as you grow older. But if you sit in Kenyatta National Hospital and look at the patients you have, they are actually young women. We were told in the textbook that if you had, you know, multiple pregnancies and many children, your risk was reduced.
Lower.
But if you sit in the clinic, you see these are women of reproductive age. You know, they have many children. They breastfed their babies because we were told having no child, or what we call nulliparity, not breastfeeding your baby, a late early pregnancy were certain risks to breast cancer. But that is not so among Kenyan women.
They
have multiple children. They breastfeed their babies because, for example, they cannot afford anything else other than breastfeeding. And they actually probably don't even know if they have a family risk because, you know, these diseases have stigma. People don't talk about them in families. Certain families don't want to be labeled as having breast cancer, and that, you know, traditionally will affect many things within the family, including marriageability of their daughters. So those, you know, stigma issues and, you know, can also affect these, you know, this whole conversation.
What about the fears of, it's the food we eat, it's the lifestyle, it's...
those are the myths. Yes, and for example, you know, diet is very important. Diet is important to keep us healthy, to make sure that our blood pressure is well controlled, in not taking a lot of salt, not taking alcohol, you know, not smoking. All those are very important as part of the whole, you know, discussion around what we put into our bodies. But not eating meat, not drinking milk, not eating eggs, being a vegetarian is not going to protect you from breast cancer. And neither is it going to cure your breast cancer by using what we call diet therapy. It will not. And it's very important for women to know it's very good to exercise. It's very good to watch your diet, have a diet low in carbohydrate and a lot of vegetables and roughage and drink a lot of water. But that will not reduce your risk of breast cancer. But it is very good to do. So the same things we described about breast self-examination, going for the correct diagnostic still stand.
All right.
In that narrative.
As we talk about age, and you demystify this myth that women in the menopause age bracket are higher at risk, is that true or is it false? And also talk to us about the age and where somebody really needs to be going for these checks annually and after every year. There's usually that guideline that you give depending on the age of the woman.
Let me just say that if you're an African woman, the majority of breast cancers actually occur in the younger age group. So between the ages of 35 and 50, it's very important for us to have guidelines to be able to carry out screening.
Okay.
And also adding the little note that I talked about, targeted screening based on your risk factors. You know, if you've had breast cancer before, you have a 10% risk of getting cancer on the other breast. If you've received radiotherapy, either to your thyroid or the lung, you also have a high risk of breast cancer. So those sort of things, in addition to the ones that I've mentioned.
All right.
So I'd like to say in our setup, young women are not exempt from getting breast cancer. In other populations, we find that breast cancer is more in the realm of postmenopausal women, but not so in our setup. So from a policy level, from a forming guideline level, we need to be aware about our own issues to be able to benchmark where we give guidelines on screening. Again, there is a risk to being exposed to too much radiation. Can I go for 2 mammograms in a year? And this is where we call for a health professional to be able to guide you about how some of these screening procedures should be. Because again, you don't want too much radiation by having very frequent mammograms. It should be based on your risk. What did your mammogram show last year? What does a doctor think is the best time to do the next mammogram? Or what can we do an ultrasound next time because of this risk of radiation? I must say the investigative procedures that are being made, you know, on and on, you know, the stereotactic mammograms and the rest, they have less radiation and are made to try and reduce this risk of being a cause of the malignancy that they are trying to prevent or to diagnose. Yes.
The fear of unknown is what makes many people not go for.
Knowledge is power. Knowledge is power.
There is this strong belief in our communities that ukianza hiyo safari ya kwenda kufanya hizo test za cancer utapata hiyo Actually, talk to people who are watching this.
Yes, and that's a very common narrative. That if you go for tests, you're inviting the disease. But that's something would like to really, a narrative that would like to really discourage. In that knowledge is power, early diagnosis is a sure promise of a cure. And of course, less investigations. Women who come early may not require radiotherapy. They may not require chemotherapy because they presented early and a surgical procedure is all they need. But of course, in the same light, let's accept the stage at which we present and the sort of modalities of treatment that we need. Cancer can be cured.
All right. This whole, test centers around really understanding your body and the size of your breast. And this has to be followed. That pattern has to be followed for years.
Yes, it
does. That then mean that for tests like a mammogram or ultrasound, you go to a specific center so that history is
not necessarily,
or what do you
but
advise?
A very, very good question. If I had my mammogram at, say, the Nairobi hospital last year, sometimes I carry that mammogram to probably go to the next place to do. If I'm transferred to Mombasa to work, it doesn't mean that I have to travel to Nairobi to be able to do my mammogram.
But you need to have the history.
Exactly. You need to have the history, probably a medical report from your doctor, and probably that old mammogram that you did a few years ago so that they can do a comparison. There are women who we find microcalcification this year. That's a change on the mammogram. And we tell them, as much as we did a biopsy and there is no cancer, we need to repeat this in 6 months to see the interval change. And therefore, if they are transferred to Mombasa or to Kisumu, they are going to carry my report and they are going to carry their old mammogram so that a comparison can be made. Sometimes that interval change, has it grown bigger? Has it increased? Is there any change in the breast on examination? Is there a lump now? Well, as there was none. can lead to, can go a very long way in probably making that early diagnosis that we seek.
But how often or how practical does it happen that just a random woman comes, no suspicion, nothing, they just come for a mammogram?
Very more common than you think. Yes, because, majority of women will have no family history, will have no genetic mutation. Although let me put a caveat there that not enough studies and research have been done in our population. But majority of breast cancers, even around the world, as much as we talk about these inherited mutations, are sporadic, cases where a woman was not expecting to have breast cancer. She actually can follow through to 5 generations and they don't have breast cancer, and she will have breast cancer. That's the majority of the stories. All
right, so let's talk about 2 scenarios. So you said the biopsies now, that is what will confirm whether there is cancer or not. So you've done that, and there are 2 cases. There's one that has tested negative, and I'm trying to use the simplest language I know.
Yes.
So one has tested negative, and another has tested positive. So talk to us about these pathways. So what you...
Thank you. Yeah. So you've had the biopsy done, and you have breast cancer.
Yeah.
The histology has confirmed that you have invasive ductal carcinoma. As an example, the next stage will be to do certain tests on that biopsy specimen, so that we can test for what we call predictive markers that will guide us with your treatment. And after we do that, we also want to stage you. We want to know, has this cancer spread anywhere else? Because depending on the stage, we'll decide what the initial treatment should be. The other scenario is a woman who has very suggestive findings on the mammogram. That's the example you mean.
Yeah.
And then we do a biopsy and there is nothing.
Okay.
There are times when I review that, I think, we probably have missed it, and I send the woman for a second biopsy.
All right.
And we find the cancer on the second attempt. There are times where I'm convinced that the findings on the imaging, and when I talk to the radiologist, they think, Dr. don't worry, this one, let's wait 6 months to do another mammogram and do another biopsy if we need to. And sometimes we find that in that interval, cancer has developed, or it has not. Sometimes the microcalcifications disappear and improve, and our suspicion goes. But we ask for continued follow-up. I usually tell those ladies that the burden they have to bear is just checking and having a high index of suspicion. So that narrative of no news is good news is not a good one. So for this other lady who has breast cancer, we do the predictive markers on the breast, we do the hormonal profiling, and usually that helps us to know what chemo shall we choose if she needs it, and what targeted therapy shall we use if she needs it. The stage is also very important, and the staging can involve doing a bone scan and CT scans, or it can involve doing a PET CT scan. Now, that's where you can have between stage 1 and stage 4 breast cancer. And for example, if we find you have stage 3 and 4, sometimes we want to give you chemotherapy first or hormonal therapy first, because at that stage we decide what the intention of treatment is. Is it to cure you? Or is it to increase your disease-free survival in where we treat you and we keep the cancer away for the longest time, but we know it will come back, or it has a high risk of coming back? Or if you have stage 4 disease, we know you are incurable, but the interventions and the treatments that we shall give shall lead you to survive for many years, a decade and a half, also depending on the molecular markers and what sequential interventions we have.
All right. You've talked about staging, and I want us to also run people through the basics of the stages of cancer. And I understand that this side of the world, most diagnoses are caught at stage 3 and 4.
Yes, unfortunately, around 68%
so talk to us about
the
dangers and the extremes.
Yes, so if you have stage 1 disease, it's very early.
All right.
There is no nodal involvement, and many women in stage 1 will just get a mastectomy or get a lumpectomy, or what we call breast conservation surgery, and probably get radiotherapy and be put on hormonal therapy. Now, in some, the surgery is all that they need and nothing else. Now we go to stage 2, the breast lump is bigger, and we do the molecular markers, and we decide if we can do, there are some molecular markers and there are some types of disease that are more aggressive than others. And therefore, even for stage 2, we may decide this breast we cannot conserve because her molecular markers are not very good. Or this stage 2 disease, let us give a little treatment before, because this is aggressive disease, before we do the operation. And then stage 3 is usually locally advanced breast cancer, where the cancer is a big lump and it has gone to the lymph nodes under the arm, but it's not metastatic. Most times we want to give some chemotherapy first or some hormonal therapy depending on the age or the comorbidities of the woman. We shrink it and then we operate. And stage 4 disease, the cancer has metastasized. Again, also stage 4 disease, there is a lot of, the outcome is also based on where has it spread, how many metastatic lesions are there, and the spread to different areas and the volume of metastasis will also affect the woman's prognosis. I must say certain types of molecular types of breast cancer are also good prognosis even in stage 4 because there are many interventions that you can do sequentially and keep the woman alive for very long.
So stage 4 does not mean a death sentence? No, it doesn't mean
a death sentence. There are many people surviving many years depending on the interventions. You're not cured. It's a chronic disease. You shall need to have regular reviews and be on treatment for a long, long time.
But you can still survive.
Yes.
But let's also talk about how you prepare a patient for this journey. We've had stories, because today the theme is all about stories and the journeys.
Yes.
Every journey matters, and behind every number there is a face, there is an individual. And they will share, they will share interesting stories about how that journey has been for them. Some don't make it to even tell the story. How do you prepare the mind of a patient who has just come and you're holding this report and you know that it is a positive? How do you begin that walk with this?
And now, as oncologists, patients are referred to us. There are some who we make the diagnosis as we go through the journey of screening, but there are some who's been diagnosed elsewhere and they come to get the oncologist to treat them. Now, sometimes it depends on how the news was broken to them. And this is where we know as health professionals, we should really... we do get training on how to break bad news because sometimes the way the news is delivered to the patient will impact their journey and the choices they'll make. We say that it's important to have counseling also involved, in giving this patient positivity, because having a positive outlook is very important. We talked about positivity during the HIV/AIDS pandemic, and that also applies to management of breast cancer and other malignancies. Family, community support. In this WHA call for every story is unique, every story matters. And that's why we're saying community support, family support, financial support at places of work, and of course, insurance support. So breaking the news is very important, and giving the patient positivity. Because even when they have stage 4 disease, they have to live with it, and they have to go through the treatment, and they have to make choices which either give them a good outcome, even with stage 4 disease, or a bad outcome in stage 4 disease. So that stage of breaking news is very important. Sometimes you gauge the patient and decide what you need to say at every stage, depending on what they can be able to receive. Because also we do a bit of psychological assessment, and we're also given training to know patients are very different. There are some who ask up from Daktari, what's my survival? In the first visit.
They want to know.
They want to know. There are some who are not ready to get that news. Even if I'm sitting with them and their daughters are asking, Daktari, how long will mom live? You look at mom, you see she's looking down, and probably she's not ready for that. And also those assessments actually, because it's a journey, can go on in a stepwise manner. Complete honesty, but delivered in a very compassionate way so that people can be able to cope.
So the state of mind
is very important. The support is very important. The affordability and access of treatment is also very important.
All right. So let's talk about the impact of some of these treatments? You mentioned, I don't know whether that is all that there is when it comes to treatment of cancer. So take us into that world, because people want to know that there is a way out. It's not all doom and gloom.
Yes.
Yeah. What are the options out there right now?
So I must say locally we have quite a lot available. There is always the odd patient who requires something unique, but in breast cancer, a lot is available locally. And I encourage women to get treatment locally because your family support, instead of traveling to a country where you are alone.
And it is possible.
But you see, that's an individual choice. But the choices should be to make you have the best outcome you can have for your individual situation. And therefore, also attract everybody who will give you a good fight in your corner. Not people who are going to hear, oh, that one has breast cancer. Let's remove her from our chama. Let's remove her from being treasurer because she's going to die with our money. You know, those sort of people are people you should cross off. You know,
you're already dealing with so
much, and then
you don't need more negative energy
people
around.
Putting you down.
Yeah.
You know, you already have a lot to deal with the disease. So, you know, that whole sort of support network is actually, you know, very necessary. You had asked about, you know, the coping of treatments. I'll start from the surgical ones, where you have a mastectomy. It's a disfiguring intervention. The woman doesn't have one breast. There are people who have such a strong family history and they have a genetic mutation where their risk of getting cancer on the other breast is so high that we advocate for a double mastectomy. We remove the sick breast and the one that is not sick because the risk is very high. But these are women who go through the whole counseling procedure and decisions are made based on what they can cope with. Some say, no, doctor, let me just deal with the first one. I shall deal with the second one as it comes. So it's a disfiguring operation. It makes a woman feel that she's not a woman.
It's sort of like you're losing your womanhood. I mean, these are...
Thank you.
Yeah, I mean,
those
you would imagine that the breast is part of what defines
but I
your
tell
femininity.
you, these women go through a lot.
Yeah.
Your husband may look at you in a different way. You know, you also look at yourself in a different way.
Motherhood is also connected to your breast.
Exactly.
So
and
you're losing
young ladies who we've removed one breast and they have to breastfeed on one breast when they get babies many years later. So all those sort of narratives, the effect on fertility, even when we come to some of these treatment choices. But what I would say from the surgical point of view, you can either have breast conservation where we remove only a part of the breast, but that's for very early cancer. I usually remind women that number one is that we have to aim for cure. So all choices we choose, if a mastectomy, removal of the whole breast is better than conservation, please let's choose that because keeping you alive is the most important thing. So we have, surgery, cosmetic surgery that can be done either at the same sitting as removal of the mastectomy or later on, depending on your risk factors and the stage that you're at. So many women get reconstruction and they look very good. I have women in their 60s who tell me, Daktari, I removed this one and now I have reconstruction and they even reduced this other one because I wanted a younger breast.
And you make it look like the way you always
Exactly. And they have breast conservation.
But just a quick question, can breast cancer spread to other parts of the body?
Yes, it can. And that's what we call stage 4 disease. Breast cancer can spread to the brain, to the skin, to the lungs, to the bone, to the liver, to the spleen. It can more or less spread everywhere. And there are certain types of very aggressive breast cancer which will even spread on the skin all over. And, it can metastasize, and that's what we call stage 4 disease.
All right.
Yeah.
So we were talking about the impact of treatment. There is the fear of fertility and how it can be compromised when you are on the journey.
And definitely
So let's talk about that.
It definitely can. And sometimes when, most of the treatments, the success of most of the treatments is to get rid of your periods. And the continued success of keeping you alive and reducing a recurrence is to make sure the periods never come back. But if you don't have periods, it means you can't have a baby. And sometimes the risk of getting pregnant after treatment of breast cancer is a real one. Because when you're doing that hormonal therapy or, fertility treatment so that we can stimulate, fertility for women to get pregnant is a risk in itself. And therefore, there's usually quite a bit of calculation and multidisciplinary discussion when a young patient had breast cancer and now she wants a baby. It's very possible. in cases where the presentation was very early and what we call the risk of a recurrence. And we usually have a discussion with the family and so on. And I remember sitting in a conference recently, and, you know, the mother of the husband said, Dr. It's not my son's fault that his wife got breast cancer. It's not his fault. He needs children. Yeah. And I looked at the young realities. They are real realities. And I looked at the young lady, and she broke down. Yeah. And it was not her fault either. Yeah. But there was how do you deal with this dynamic? There was a very high risk that if we put her through, you know, the fertility treatment and so on for her to conceive, there was a great danger that her cancer may come back if she stopped the treatment that she was on. So those are real situations, and that's why we talk about every story is unique and every story matters, and there is a face to every statistics, and their circumstances are totally different.
Do we have cases where somebody went through treatment and they still got pregnant later?
Yes, yes, and those ones exist. Yeah. And that's why I say, you know, two women sit in my reception and say, Dr. why did you tell that other one this and me you didn't tell me this?
Exactly.
You know, every story is unique. Every risk is unique. Every stage is unique. Every molecular level of tests is unique. There is no duplicate treatment for everybody. They are very different, and the circumstantial considerations are very different, and sometimes require a whole multidisciplinary discussion to be able to see what is good for one woman.
So let me speak for that woman who could be watching. You said the cancers, the way the trend is going, younger women are actually falling.
Yes, we make a diagnosis of breast cancer when you're pregnant.
Yeah. So let's talk about that woman who could be watching, and they fear they may get that positive diagnosis, but they want to have children. They want to live their life as normal as they can. They come to your office, you're having this conversation with them, and you're putting these options on the table. How do you balance the dynamics just so that you can address her concerns and also help her when it comes to managing this cancer and increasing her survival rates? How do you go about that?
The first discussion is that to be very clear about what their unique circumstances are, and not to make choices based on another person's, you know, sort of description of their disease, and not to make choices based on what anyone else wants, even their spouse or their children. Your story is unique, your circumstances are unique, and number one is choose to live, aim for cure. Now, there are very complex situations where women tell me, Dr. It's okay, I get my baby, I leave a progeny, and I die. Yeah. I've chosen not to have treatment so that I can have this baby.
Reality.
But the burden as a doctor is to make sure that the knowledge and the information and the multidisciplinary sort of resources you call for is that you've done a very good job in this person making that choice, so that later on, of course, we regret when we lose a patient, but later on, it was not a mistake. It was not that anything was left out. It was that this person chose with all the information that they had. Yeah. And sometimes that's why it's community pressure for people to be, you're identified by the number of children that you have, which I think is not correct. Yeah. And that's why, you know, with this story about every story matters, every statistic has a face, is also for the community, the family, to also not put pressure or be able to support this person in a different way.
All right. A quick question that just came in, Dr. A lump on the arm and underarm, does that signify that there is breast cancer?
No, having a lump is not equal to breast cancer, and that's a very good question. Yeah. It's highly suspicious, but the most important thing is go for a medical checkup, do the usual investigations, and by all means have a biopsy. It could be a breast abscess, you know, it could be something else.
All right. We are almost running out of time, but I want us now to elevate this conversation to the point of action that needs to be taken as we move in dealing with cancer in our country. First of all, from where you sit in your own assessment, what is the research showing us? And you know, what change of strategy do we need to implement so that we improve the outcomes when it comes to survival, we improve the outcomes when it comes to access to treatment and even diagnosis or detection of cancer?
The call to action is, you know, having these awareness campaigns is impacting knowledge about the individual risk. It is changing the health-seeking behavior of the individual in that I feel a lump, let me go for a test. Let me do what it needs to be able to treat my cancer if I have it. Number two is from a policy or advocacy level to make sure that if that individual wants to do the correct thing in health seeking, let's create access for them. Let's make it easy that you don't have to come from Kwale and go all the way to Kisumu or Mombasa to be able to do your breast ultrasound or your biopsy. Because sometimes these difficulties are what deter an early diagnosis. Let us empower community health workers to be able to talk to women, empower them to be able to seek, some of these, diagnostic procedures. So we've changed the individual, but from a policy level and government level, we've created access. And after the diagnosis is made, there are people who ask me, so if I have breast cancer, I have no money, I have nothing, how will I get treated? Because that's also a deterrent. Why should I get a biopsy where I have no hope of ever getting the correct treatment? So from a policy level, it's creation of this access. And I usually say, let's not always speak about what can my country do for me, is what can we do for ourselves. If we're in positions of having CSR that can be able to make these sort of changes in our community, if we're in a policy and level where we can be able to create policy where there is access to these women, it's very important. We know using the MES, system of, the ultrasounds were, ultrasounds, investigative procedures, mammograms were actually equipped in many county hospitals. And I think, creation of this awareness in people that I can go to the provincial general hospital, the district hospital, or the level 3 hospital and be able to get a mammogram, a pap smear, and also get my mastectomy is also very important. So that creation of access, and also sort of the empowerment of some of this health financing so that our people can be able to afford care.
Yeah, cancer is expensive.
It's very expensive to treat. And it's expensive to the individual and it's expensive for government.
Yeah. All right. Talk to the men. And forgive me for doing this last, but I don't want to end this show before.
So let's talk to the men. They are very important in our community and in our society. But men too can have breast cancer. If you have a unilateral lump, please go to a doctor. Please get a biopsy. Do not shy away from that. Men also get mastectomy. Probably the effect on the anatomy is a little less than women. They get radiotherapy. They go on hormonal treatment. So please see a doctor. And also men are very important as a support for our women. They are very important in creating advocacy for our women so that we can be able to create some of this access. They are also very important in our families because sometimes they are the providers. They are the ones with the money to pay for their sisters or their wives or their mothers to be able to access treatment. So they are quite important and pivotal in this narrative, and we can't do without them.
All right. And beyond the numbers, the statistics, the health policies, and what needs to be done, there is a story that lies behind every number that we are talking about. And that is the theme for this year's, celebration of the Cancer Awareness Month. There is that young lady who found a suspicious lump, went to the hospital, and her whole life changed. That is the story we are celebrating. There is that middle-aged woman probably who found strength in a community that really stood with her during her journey battling cancer. That's the story we want to hear out here. There is a woman out there who turned her pain into purpose and began advocacy just because of what she went through. That's the story we want out here. And those are the stories we are celebrating. And sometimes
the advocacy is sometimes connecting patients and having patient support groups so that, I'm not alone. And I find that there are very many patients who've gone through the journey who are very compassionate, even just to talk to another woman. They don't even know, to be able to offer her some psychological support. So those networks too exist.
Thank you so much.
Thank you very much. Yes, I hope we shall make every story matter.
We make every story matter and elevate this conversation beyond October. Let's talk about this more, not just in the month of October. Dr. Gladwell Kiarie, a consultant medical oncologist, as we're talking about breast cancer on the show this particular morning. Asante once again, Daktari, for your time. And thank you for watching. Thank you so much for also what you're doing in your small small corner of the world to change the narrative around breast cancer and all types of cancers. We celebrate you, we celebrate the warriors, the survivors, and those who've fallen. We also remember them. Thank you so much for watching the show this morning, and that's how we wrap it up.